Screen?
Yeah.
Let me see. Okay. All right. Meanwhile, while Megan's like sharing her screen, so I have like a brief bio about Megan, the first presenter of this breakout room. So Megan is a public health undergraduate student with a concentration in global health here at CSUF Fullerton. She's a senior and has been involved in research with Dr. Lahua Mamudu for nearly over 2 years. She hopes to attend a graduate school for a master degree in the future. And we wish you best luck. And if you want a letter of recommendation for Dr. Mamudu or us, please be willing to help you succeed in your graduate school. Megan, you ready?
Yeah.
Okay. Yeah, you can start your presentation now.
Okay, thank you. So yeah, hi everyone. My name is Megan Gray. I will be presenting on the prevalence trend and association of health insurance with radiation treatment among women diagnosed with breast cancer in Tennessee from 2005 to 2017. Um, like Dr. Finn mentioned, I am an undergrad student and my mentor is Dr. Mamudu, and I am under the Department of Public Health. And so just to give a little background, Um, so breast cancer, it is the second most common but the deadliest cancer disease among females in the United States. And multiple studies have shown that radiation treatment has improved the survival rates of patients with breast cancer. And so I decided to add a little graph here that basically talks about Tennessee's most populous counties, and it kind of shows the range of the uninsured rates. You can see in some areas the uninsured rate can be as low as 3.4%, and then it's even as high as 13.9%. And a lot of this could just be due to the certain counties. So residents of rural counties, they still lack insurance at higher rates than those living in urban counties. So it might be wise to why the uninsured rate tends to be pretty different among the counties. And then, so the hypothesis for this study was that individuals with private health insurance are more likely to get radiation treatment for breast cancer than individuals with public health insurance. And the objective of this study is to assess the prevalence trends and association between the type of health insurance and radiation treatment of breast cancer, identify the differences in breast cancer radiation treatment across health insurance, and even just examine the odds of health insurance association with breast cancer radiation treatment. And so now I'll be going over the materials and methods portion. And so our data was received from the Tennessee Cancer Registry, and it was from 2005 to 2020. Our study design was a cross-sectional study, and our study population was individuals diagnosed with breast cancer in Tennessee. And the exclusion criteria was essentially just any individuals with missing data of any variable of interest that we decided to include in this study. And the main inclusion criteria were individuals identified as females, those who were aged 18 years and older, individuals who received radiation treatment, and individuals with any type of health insurance. And for health insurance, the three categories were those who were self-paid / uninsured, those who were had public health insurance, that could be like Medicaid, Medi-Cal, and even just those that had private health insurance. And so our total sample ended up being 50,650 individuals. And our dependent variable was radiation treatment, and our independent variables / covariates were, again, health insurance, marital status, state of diagnosis, and treatment time, county of residence, race and ethnicity, and also just age. And so we kind of ran multiple tests. So we ran frequencies, prevalence, and the trend of radiation treatment that was estimated. We also ran a chi-square test, which was performed to examine the differences in radiation treatment among independent variables / the covariates that we had. And lastly, we ran multiple adjusted multivariate logistic regressions. And those were performed to essentially assess the likelihood or the odds of radiation treatment among the independent variables / covariates. And so for that one, we kind of ran 4 different models. So we ran the unadjusted model, age-adjusted model, age and race-adjusted model, and lastly, the fully adjusted model. And so now I'll be going into the results portion of this presentation. And so in this first chart, you can kind of see it's the trend of breast cancer radiation treatment by the type of health insurance. So you can see that public and private are slowly going down. You can see that public tends to be a little bit higher than private, and the uninsured tends to vary depending on the year. So you kind of see it going up and down depending on the cycle for receiving radiation treatment. And then this is just the age prevalence of radiation treatment by health insurance. So as you can see, the older that you get, for example, those who are 75 and older, and they are uninsured, they tend to have higher prevalence of receiving radiation treatment in comparison to having private or public health insurance. And I did think it was kind of interesting that, again, public tends to be a little bit higher in comparison to private when it came to receiving radiation treatment for the age. And then this is just the race prevalence of breast cancer radiation treatment by the health insurance. So again, another thing that I thought was interesting is that for the other category, which would be anyone who's not white or black, those who are uninsured tend to have a higher prevalence rate for receiving breast cancer radiation treatment in comparison to those that have private or public health insurance. And as you can see for the white category, those who had public health insurance tend to have a higher prevalence of breast cancer radiation treatment, and you can kind of see that same trend in the black category for our population. And then, so this is just the county prevalence of radiation treatment by health insurance. Like I had mentioned earlier when I was talking about the different counties and the uninsured rate, this is something that we thought would be interesting to look at. So you can see that those who are in the Appalachian region, they tend to be lower when receiving breast cancer radiation treatment across all the different types of health insurance. It appears that those in the non-Appalachian counties tend to have higher rates for that, but there wasn't a huge gap between those two. And then so now I'm going into the adjusted models. And so this is just the likelihood of radiation treatment by health insurance. So with the fully adjusted model, we saw that those who had public health insurance had higher odds of receiving radiation treatment in comparison to those who had private or uninsured health insurance. And for the unadjusted model, we kind of saw that it was those who had private health insurance tend to have higher odds of receiving radiation treatment in comparison to those who were uninsured or public. And then this is just the age and race adjusted model. So for this one, we saw that those who had public and private, they tend to have higher odds of receiving radiation treatment in comparison to those who are uninsured. But for this one, we saw that public tend to have higher odds in comparison to those who had private health insurance. And so this is just a summary of our research findings. So we saw that out of the 50,650 breast cancer patients, around 43% received radiation treatment. And we saw that there was a fairly steady decline in the prevalence trend of breast cancer from 2005 to 2017 among the patients with private and public insurance. And with private insurance, they did tend to have a higher prevalence rate, with it being 59.3% respectively. And in the unadjusted model, we saw that breast cancer patients with private insurance had higher odds of radiation treatment compared to self-pay or uninsured. And in the fully adjusted model, we saw that those with public insurance were more likely to receive radiation treatment in comparison to those who were uninsured. And so the results of the study have shown that private and public insurance may impact the likelihood of receiving radiation treatment, and individuals with public insurance were more likely to receive radiation treatment than those with private insurance and self-pay or uninsured. And given that radiation treatment improves breast cancer patient survival, knowing and understanding the influence of insurance on radiation treatment is necessary to improve breast cancer treatment strategies and survival rates. And since private health insurance has higher cost-related copays and deductibles than public insurance, it can be associated to a delay in treatment care. Therefore, we need a streamlined private insurance policy that can enhance breast cancer treatment outcomes. And one of the ways of just enhancing these treatments in minority communities is just ensuring equitable access to high quality care. And then that concludes my presentation. Are there any questions or comments?
Wow, this is very fast-paced presentation and full of information. Is there anyone has questions to Megan? or you can ask on the chat as well. I have a quick question, Megan. So I'm not really sure. I might miss at the beginning when you presented. What is the percentage of the uh, individuals who receive private insurance compared to public and uninsured? Do you have that descriptive statistic at the beginning in
Yeah,
your data set?
we don't have, or I didn't put that exact descriptive
Mhm.
statistic, but I believe it's somewhere here. It kind of talks about the prevalence trend, so kind of how it raises and lowers. So for the public insurance, you can see here that it's around like 60%, and for those who have private, it's around 50. So it's kind of like a small gap. I wouldn't say it's very huge, but for the uninsured,
Mm-hmm.
tends to be closer to the public.
I see.
And thank you for your question. That's a good question.
Yeah, I just want to know in terms of like the number of individuals for three groups, right? Because you compare all the three groups to see the prevalence of the breast cancer radiation treatment, right? Like I just want to see when you compare, is that all the three groups is like significantly different in amount of like people who insure in the public, insure in the private insurance or uninsured. So it's just curiosity, but any other questions?
Yeah.
Oh, yeah, that's on the chat too. What the difference between fully adjusted model and non-adjusted model? It's from Rolla.
Yeah, so the fully adjusted model basically means that we account for all the variables and the covariates and their influence with our results, where the non-adjusted model means that we just don't take into account the influence that the variables have. So for example, for the age and race adjusted model, for that one, we kind of take into account the influence that age might play in receiving breast cancer radiation treatment, and also the influence that race might play in also receiving radiation treatment. That is a good question. Thank you for that. I learned about that this year, so it was actually really interesting to kind of perform those tests.
Okay.
I think it honestly, so she said in the chat, so it's a better representation.
Mhm.
I think it honestly depends on looking at the population. So I know Tennessee has a high population of those who are Black and white. So I would say if there's typically a population that has maybe like a higher percentage of race of one category, it'd be kind of better to kind of adjust and see how certain races could influence the likelihood of treatment. So I think it just depends on like the population. Because of how diverse Tennessee is, we thought it'd be interesting to kind of look at age, race, and also take into account all the other variables, which is why we also did a fully adjusted model. And thank you for your question. Yeah, of course. Of course.
All right. If you have more questions, you can like post on the Zoom chat, and then if we have time later at the end, we can come back and like address all this.
Yeah.
So the next presenter is Josh Rodriguez. Are you here, Josh?
Yes,
Yeah. So can you share your presentation? And then
of
meanwhile,
course.
I will introduce Josh. He's a second-year Master of Public Health student at Cal State Fullerton. He received his Bachelor of Science from UC Davis, majoring in global disease biology. It was here where Josh obtained his first introduction to research, volunteering in a microbiology lab with Dr. Rainey Tollist. Yeah, sorry if I pronounce her last name incorrectly. Josh continues his research journey today and working with Dr. Lahua Mamudu as part of his integrated learning experience. If you're not really sure about what is integrating learning experience, is part of the uh, master project for graduation. Josh, you ready?
I'm ready, Dr.
Okay.
Pim.
I give
Th-
you time. Yeah.
Thank you for the lovely introduction. And so, hi everyone. As Dr. Pim introduced me, my name is Jorge, and along with my advisor, Dr. Mahmoud, we investigated the association of general health status with depression among the Hispanic Latino population in the U.S. And so a bit of background on our project, as of 2021, 20.7% of the Hispanic population in the US have been medically reported to have some kind of mental illness. And then there have been studies sampling Hispanics that have indicated that 6.8% of Hispanics have experienced at least a major depressive episode. There have also been studies that have determined that self-perceived general health status has been linked to influenced mental health illness, including depression. And specifically, there has been a Japanese study sampling middle-aged and elderly males and females that have found that those with poor and very poor general health status have a higher prevalence of depression in comparison to those with excellent, good, and fair general health status. So has also been studies that determine that social demographic, socioeconomic, and health behavior factors have also been associated with general health status and depression. For example, the individuals that lived in areas of poverty and low income and educational levels were more at risk for lower perceived health status and reported higher levels of depression symptoms. A German study reported that health behavior factors such as body mass index had a significant association with depression and low general health. And to our knowledge, there isn't necessarily anything in the literature that has assessed the link of general health status and depression among the US Hispanic Latino population. And so our aim was to assess the temporal trends and associations between general health status and depression status among the Hispanic Latino population in the US. And our hypothesis is that Hispanic and Latinos who self-reported fair and poor general health status are more likely to experience moderate to severe depression. So this research project was a cross-sectional study. We utilized data from the Health Information National Trends Survey, also known as HINTS, and we included the years of 2011 through 2012, 2014, 2017 through 2019, and we excluded the years of 2015, 2016, and 2013 because those were the years that the dependent variable or depression variable was missing from the survey. The samples were weighted to obtain nationally representative estimates. And as I alluded to earlier, the dependent variable is depression, but more specifically, it's the Patient Health Questionnaire 4, which is a 4-point tool for depression, which utilizes 4 variables: little interest, hopeless, nervous, and worry. Within that, there are 4 depression measures that we utilized. Well, 5 actually. No depression, mild depression, moderate depression, and severe depression. That's 4, sorry. And so the independent variable that we utilized was general health status, which is represented by the question in the HINTS survey of, in general, would you say your health is? And then they would, the respondent would self-perceive their general health status. And then the measures for that was excellent, very good, good, and fair, and poor. We also had social demographic covariates, socioeconomic covariates, and health behavior covariates as well. So for our statistical analyses, we conducted a bivariate chi-square test to evaluate the associations of general health status and depression among Hispanic Latinos. We had prevalence measures for depression as a temporal trend from 2011 through 2012, 2014, and 2017 through 2019. We also assessed the annual average percent change over time. And we conducted adjusted logistic regression models to evaluate the odds of depression. So here we have the relative risk of depression among Hispanic Latinos between poor and fair, and good, very good, excellent general health status. And we see here that those Hispanic Latinos with fair and poor general health status are 4.73 times as likely to be at risk for depression status of severe. In this figure, we have a trend plot showing the prevalence of depression by general health status among the Hispanic Latino population from 2011 and through 2019. And we see here in the red that those with the general health status of poor consistently appear to have amongst the highest prevalence of depression in comparison to the other general health statuses. We also see here that those that have a general health status of excellent, very good, and good have experienced an increasing trend of depression, of prevalence of depression, over this course of time. We can see this also occurring in figure 2, where we have the temporal trend and annual average percent change of depression by general health status. Up on the top, on the very top rows, we have the annual average percent change over time. And Hispanic and Latinos that have a general health status of excellent, very good, and good have experienced a substantial increase in their percent change of depression at 56.3%. We also do see a slight increase in those with fair and poor general health status at 1.2% over time. And then we also have here the adjusted odds of depression by general health status among the Hispanic Latino population in the US. And we see here in the fully adjusted model, adjusting for all health behavior, socioeconomic, and social demographic covariates, that the Hispanic and Latinos with fair and poor general health status are 3.57 times as likely to be depressed in comparison to those with excellent, very good, and good general health status. And so our results do support our hypothesis that Hispanic and Latinos who self-reported fair and poor general health status are more likely to experience moderate to severe depression. Our findings showed that Hispanic and Latinos with a general health status of fair and poor have a higher risk of experiencing moderate to severe depression than those with a general health status of excellent, very good, and good. And as I previously had said, those that with fair and poor general health status are 3.57 times as likely to be depressed compared to those with excellent, very good, and good general health status. Our findings support the previous literature that self-perceived general health status influences depression status. And so our study was essential in helping to develop a policy, intervention to address the growing mental health problems among Hispanic and Latinos in the United States. Our study was the first to find a link between self-reported general health status and depression among Hispanic and Latinos, with those with poor and fair general health status more likely to experience depression than those with excellent, very good, and good general health status. But further research is essential in understanding the complexities of general health status and their impact on mental health among Hispanic and Latinos to provide appropriate culturally effective interventions. We also think that there could be a potential use of general health status as a screening tool for Hispanic and Latinos at risk for symptoms of mental health. And so our project does not come without any limitations. We are unable to establish any causal relationship between general health status and depression, as hence is a cross-sectional survey. Self-reported data could have recall and social desirability biases, which can affect results. And there were small sample sizes among some of the variables that could have affected prevalence measures of depression. So for our future steps, we would like to investigate how general health status is associated with depression status during the COVID-19 pandemic among Hispanic and Latinos. Studies have found that the pandemic has disproportionately affected mental health of Hispanic and Latinos. So it'd be interesting how this association has changed over from 2020 onwards. So I'd like to give a special thank you to my mentor and advisor, Dr. Mamudu, and also for everyone here for giving the space to me to hear my presentation.
Thank
Here
you
are my
so much.
references, and thank you.
Thank you. So due to we have a very limited time, so please post your question on the Zoom chat, and then we will, after we finish the presentation, if we have time, we can let the presenter to address, all your concern or question. If not, so we will collect all your question on the Zoom chat, and then we'll send to the presenter and get back to you to address that later. So Daisy, I believe you're here. Would you mind to share your presentation while I'm introducing you to the audience? So Daisy Mendoza is the student from the Department of Public Health. She is a current member of the ESG as well as NARE, NAARE, Neurocognitive Aging and Analytic Research and Education Scholar. She also a student leader serving in the house and residential engagement communities on the CalSTET Fullerton campus. Please welcome Daisy.
Hi, everyone. My name is Daisy Mendoza. I am an undergraduate student researcher, and my mentor for today's, presentation was Dr. Mamuju. So I will be presenting trends and disparities in surgical treatment among married and unmarried Black women diagnosed with breast cancer in the 2005 to 2017 Tennessee Cancer Registry data. Okay. So beginning with intro. So breast cancer involves the abnormal growth of cells in the mammary glands. In the US, breast cancer mortality is the highest in Black females, while also being the second contributor to cancer deaths among women. Surgery is an effective treatment for breast cancer. Black women are more likely to be diagnosed with cancer, but are less likely to undergo breast cancer surgical treatment, which we are calling it BCST throughout the presentation. Historical events involving unethical clinical practice contribute to the current mistrust in Black female patients. And given how impactful breast cancer can be in the human body, it is important to know factors that are associated with BCST. Our research objectives are to assess differences in the surgical treatments among patients diagnosed with breast cancer and to estimate and examine the magnitude and direction of the association of breast cancer surgical treatment and covariates. So our research data, so we use the Tennessee Cancer Research data from the years 2005 to 2017. The data analyzed included women diagnosed with breast cancer who had and did not have surgical treatment. So for missing data, non-response, error to response, and multiple responses were excluded. Our sample consisted of 7,205 Black women aged 18 years of age and older diagnosed with breast cancer. So for the data description, our dependent variable that that was in our study was breast cancer surgical treatment, or BCST, and our independent variables included age, county of residence, health insurance type, cancer stage, cancer grade, and time to treatment initiation. So now going to the analytical approach, we conducted prevalence rates, chi-square tests, and stratified multivariate logistic regression analysis. With this, we found the percentages, adjusted odds ratio, 95% confidence interval, and a p-value of less than 0.05, which would lead our results to be statistically significant. Now for our results, so here we have a prevalence trend. So basically we are looking at prevalence rates trend of Black married and unmarried patients who received breast cancer surgical treatment in Tennessee throughout the years 2005 to 2017. What we could see here is that married, which is in blue, is above the unmarried group. So we could tell, or what we could interpret from this graph is that the married have a higher prevalence trend of undergoing breast cancer surgical treatment during this capture in time. Now, this second figure, it represents the prevalence rates of Black married and unmarried patients who received breast cancer surgical treatment by age. So we had different age categories, so 45 and so like less than 45, we have 45 to 54, 55 to 64, 65 to 74, and 75 and above. And similarly to the last figure, the married are in blue and the unmarried are in orange. And we can see that the married is consistent throughout each age group or each age category. And it just shows that the married group has a higher prevalence, even when looking at the age categories for this specific figure. Now, this figure is representing the likelihood of insurance status associated with breast cancer surgical treatment among married and unmarried Black patients. adjusting for age, and all covariates. All covariates are the independent variables that were in the small box from previous slides. So respectively, Tennessee, looking at the years 2005 to 2017. So what we could see when adjusting for age, or by adjusting for age, or given the person's and how likely they are to undergo surgical treatment. So we are seeing that people with private and public insurance actually have a higher likelihood when compared to the reference group, which we have as self-pay or uninsured, which is a 1.00. So this is also seen when in the age adjusted, the unmarried specifically, you see that the orange and gray, which is public and private, are both have a higher likelihood than the self-pay uninsured. It is also is same as the full adjusted model. The married and the unmarried both show that when having private and public insurance, they have a higher likelihood to undergo breast cancer surgical treatment compared to the group with self-pay uninsured. And now this figure, it demonstrates the likelihood of time to treatment initiation associated with breast cancer surgical treatment among married and unmarried Black patients, adjusting for age, insurance, and all covariates, respectively, and also looking at the years 2005 to 2017. So for this one, we see that patients that have they have their surgery after the years, after the weeks of 3.57, which was our median that we found when, find a median of the weeks in our data, we saw that it was more likely for the unmarried group to have surgery during the more than the 3.57 weeks. And this was also true for the insurance adjusted category model. And this actually was different when we adjusted for all the other variables. So that's when the married group had a higher likelihood of undergoing breast cancer surgery, surgical treatment, which was something we found fascinating. And then our last figure, it represents the likelihood of the grade of cancer associated with breast cancer surgical treatment among married and unmarried breast cancer patients, adjusting for age, insurance, and covariates. So for this one, we actually found really cool results. So our reference group is the 1.00 or grade 1. Grade 1 represents the early stage of cancer. So for every single model and group, so for married and unmarried, we found that all groups had a high likelihood when we are specifically looking at grade 1. So that was pretty unique. Now, our research contributions and limitations. So there was a decreasing trend in the prevalence rate of breast cancer surgical treatment among both married and single unmarried Black breast cancer patients. Adjusting for age and insurance, patients with all cancer grades had a decreased likelihood of receiving breast cancer surgical treatment than those with grade 1. Patients with private and public insurance had increased odds of breast cancer surgical treatment compared to self-pay/uninsured patients, regardless of marital status after adjusting for age. So our limitations, because our study does come with limitations, cancer registry data is a cross-sectional type of study design. Hence, it is difficult to draw a causal relationship. We are more talking about associations. Data were self-reported, therefore, there may be some response bias that can impact our results. Hence, caution must be taken when using our results to support policy implications. And our conclusion, our study allows for a better understanding of some of the factors that influence breast cancer surgical treatment among married and unmarried Black patients to inform target and effective health interventions to reduce health disparities. So here's my reference, and if you guys want to take a moment to follow me on LinkedIn, this is my profile picture and the QR code, and thank you. That's it. Thank you. Oh, Dr. Pim, I think you're muted.
Sorry.
Again. Yeah, it's fine.
Thank you, Daisy. If you willing to share your linking code on the on the Zoom chat, on link. We will appreciate that. Yeah.
Okay.
Share on that. And thank you so much for your presentation. It's very interesting to study on a particular factors that affecting the surgical treatment on the cancer. Again, if someone has a particular questions to Daisy, please share on the Zoom chat so she'll be able to answer it. Because we have limited time, we have to proceed to the last presenter, Alberto Murguia. So please share your presentations and I will introduce him. He will be graduating from CSUF Fullerton in this May 2024 with a bachelor's in public health. Alberto has participated in the Summer Undergraduate Research Academy where he was mentored by Dr. Lahua Mamudu. He and a fellow student work on identifying disparity in surgical treatment for female localized malignant breast cancer in Tennessee. Congratulations, Alberto intends to continue his education at UCLA for MPH in epidemiology in this fall semester. All right, you ready?
Thank you, Dr. Prim, for the introduction. Really quick, just the title of my abstract is Disparities in Sociodemographic Factors and Health Insurance Associated with Distant Stage Breast Cancer Diagnosis, Tennessee Cancer Registry Data Analysis.
Okay.
Righty. Breast cancer is the most common form and has the most common form of cancer and has the second highest mortality rate among females. According to the National Cancer Institute, the cancer stage at the time of diagnosis influences the chances of survival. I've attached 2 figures that show that majority of the cases are in the localized stage. And when you look at the 5-year survival rate, they do have the highest percentage. But when looking at the minority, the distant stage, they have the lowest 5-year relative survival percentage. So according to the Tennessee Department of Health and the CDC, Tennessee is ranked 38th in the highest incident rate of female breast cancer, but they are ranked 6th in the highest mortality rate within the US. The Black population of Tennessee makes up about 14% of the new cases, while they make up almost 18% of the total cases within Tennessee. So my hypothesis, or our hypothesis for this analysis, is that the older females and females without health insurance were more likely to experience a distant stage breast cancer diagnosis in Tennessee. Additionally, Black females are more likely to experience a distant stage breast cancer in Tennessee. The objectives of this study was to examine the influence sociodemographic factors and health insurance have on distant stage breast cancer within Tennessee, and then identifying differences in distant stage breast cancer diagnosis across these sociodemographic factors and health insurance, as well as estimating and examining the magnitude and direction of the association of these sociodemographic factors and health insurance with the distant stage breast cancer. So this was a cross-sectional study, and we used the Tennessee Cancer Registry data from 2005 to 2020, which gave us a total sample of 62,482. The inclusion criteria for this is that individuals identify as female, they're aged 18 or older, and that they were diagnosed with in situ, localized, regional, or distant stage breast cancer. For exclusions, just anyone who was who had any missing data of interest, they were excluded from this. For the measures, I did have to categorize the sociodemographic factors and socioeconomic factors. The outcome variable of interest was just that distant stage breast cancer diagnosis, and then independent variables and covariates included cancer stage, age, race, marital status, and health insurance. For the statistical analysis, I estimated the frequencies and prevalence of the distant stage breast cancer. I also did a chi-square test to examine the statistical differences in the distant stage breast cancer. And lastly, conducted adjusted multivariable logistic regressions to assess the likelihood of distant stage breast cancer. This first figure shows the distribution of the distant stage breast cancer by age. It shows that females ages 75 and older had the highest percentage at 5%, and that females aged 65 to 74 had the lowest at 4.1. For figure 2, it shows the distribution by race, and it displays that Black females have the highest percent at 6.8, and then it's followed by females of other races at 6%, and then trailed further behind by white females at 4.1%. Now this is figure 3, and this one shows the distribution by health insurance. Females who are uninsured have the greatest percentage at 17.3. And what's really interesting is that females who have, females who are uninsured, this is more than 3 times females who have public health insurance, and then almost 5 times more than females who have private health insurance. So now figure 4, this displays the likelihood of distant stage breast cancer by age. The health insurance adjusted model shows that all age groups have an increased likelihood of distant stage breast cancer, except for those who are 66 to 74 years of age when compared to those who are 75 years or older. The full adjusted model also reflects the same findings, just at different magnitudes. Figure 5 shows the likelihood by race. In this age-adjusted model, Black females have the greatest increased likelihood of distant stage breast cancer when compared to white females. But when we look at the health insurance adjusted, again, Black females have the greatest increased likelihood. However, females of other races, their increased likelihood was not found to be significant. Lastly, when we look at figure 6, this one displays the age and race adjusted likelihood for distant stage breast cancer by health insurance. So females who have any form of health insurance have greatly decreased the likelihood of a distant stage breast cancer diagnosis. However, those with the private health insurance have the greatest decreased odds. So just a quick summary again of all of that. So 4.5% of all the cases have a distant stage breast cancer diagnosis. The subgroups with the highest prevalence were females aged 75 or older, Black females, single and unmarried females, and lastly, the uninsured females. All groups had increased likelihoods of, all age groups, had increased likelihood of the distant stage breast cancer, except for those 65 to 74 years of age when compared to the 75 and older. And then Black females had increased likelihood for distant stage breast cancer. Lastly, the females with health insurance had a decreased likelihood of distant stage breast cancer. So these results indicate that age, race, and health insurance influence distant stage breast cancer. Although there was a greater prevalence of distant stage breast cancer among females 75 years or older, the likelihood of distant stage breast cancer does seem to decrease with age. So that's something I was interested in. And then as hypothesized, Black females had the greatest prevalence and had the greatest increased likelihood of distant stage breast cancer. Also hypothesized was that individuals with, or females with health insurance did have significantly lower prevalence and decreased likelihood of a distant stage breast cancer. So historically, the Black population has experienced injustice and discrimination from the medical and public health field, as well as many other fields. Those are just the ones of focus right now. This has resulted in a justified medical mistrust. And furthermore, we operate in a capitalistic society, and unfortunately, the medical field is not exempt from being a market that many people want to try and control. The results of this study support that medical mistrust from Black populations and other minorities, as well as the lack of health insurance, are deterrents from seeking medical attention, which in turn can lead to those increased odds of distant stage breast cancer. Streamlining the healthcare system, along with using coordinated and targeted interventions, can reduce the late breast cancer diagnosis among women in Tennessee and ultimately lead to the reduction caused by the disparities. In conclusion, this study demonstrates that age, race, and health insurance status disparities exist and significantly influence females having a late or distant stage breast cancer diagnosis. To improve the quality of life and survival of all breast cancer patients, health policies and interventions should be employed to address these disparities. So I know we're out of time, so here's my email. And then I am also on LinkedIn. You can just look me up, Alberto Murguia, and we can connect there if you'd like. thank you all so much for putting this together, and thank you to Dr. Mamudu. I wouldn't be, doing this or presenting without him. So thank you.
Thank you, Alberto. Okay.
Awesome. If you guys have any questions, please leave it in the chat. This will actually conclude our presentations, our student presentations. Your hard work and effort definitely show, and we cannot wait to see what you do in the future as public health professionals. Please return to the main meeting room now for closing remarks. Thank you.